Welcome to Learn Radiology, everyone. I'm Brent Weinberg. In today's video, we're going to keep going on our CNS autoimmune and inflammatory lecture. Today, we're going to talk about two of the more common inflammatory diseases that you may see in the spine. So in the past couple of lectures, we've talked about demyelinating disease and encephalitis. We've talked about some mass-like inflammatory diseases like sarcoid and orbital inflammatory disease. For this lecture, we're going to focus on spine inflammatory diseases, namely transverse myelitis and sarcoid. Now, you can definitely see multiple sclerosis in the spine, but since we've talked about that a little bit, we're going to leave that aside for today. In some of the future lectures, we're going to talk about amyloid-related disease and some vascular inflammatory diseases, so be sure to stay on the lookout for those. If you haven't seen the lectures previously, be sure to go back and check those out when you have time. So for spine inflammatory diseases, the two main things that you have to think about are transverse myelitis, which can be inflammatory or infectious, or a demyelinating transverse myelitis. Also, something that we see pretty frequently is sarcoidosis in the spine, and the spine is a relatively common location where sarcoidosis is manifested. So we'll start with this case of a 56-year-old woman who's got weakness, difficulty breathing, and autonomic dysfunction. And here you see some images from the cervical spine. And we have a T2, we have a T2 with fat saturation or a stir here. And this abnormality is a little bit subtle, but what you see is a kind of a long segment T2 abnormality here, mostly in the anterior cord. On the fat side, it's a little bit more conspicuous. Here you see the pre and post contrast, and the finding again is kind of subtle. It's not super obvious, but you've got a little bit of enhancement here in the anterior part of the cord, that part that's T2 hyperintense. Here you just see some axials through that same region. This is a T2. You see this abnormal symmetric T2 signal in the anterior cord. Maybe a little bit of hazy enhancement there as well, so that you can definitely see. Here you have diffusion imaging, and this is an important negative, right? If you have an infarct of the cord, you can have long segment abnormalities, but you expect that to be abnormal on diffusion. So this is a case of transverse myelitis. In this case, it was caused by West Nile virus. But when you have transverse myelitis, most commonly it's an isolated infectious or inflammatory syndrome. You see it in the spinal cord. It's most commonly in the cervical spine. Often it will be associated with a recent viral illness, so people will know that they've gone through a viral syndrome. But the key feature is a long segment T2 hyperintense lesion, typically being one vertebral body or more. So MS, for instance, like you'll have shorter lesions that are one vertebral body or less, but these can be two or more. Now, there's a specific syndrome, neuromyelitis optica, in which case transverse myelitis or long segment transverse lesions are associated with an optic neuritis. That's called neuromyelitis optica. Now, many times these are self-limited, and the treatment is often limited to supportive care, or very similar for MS. So you'll be treating it with the steroids and IVIG and kind of acute anti-inflammatories. Here you just see the same findings that we talked about. You see this long segment T2 abnormality, in this case going from about C3 to about C6 or C7, a little bit of hazy thin enhancement there. Here you just see the same things on the axial that we talked about. Now, in this case, it's confined to the anterior horns, but something I want to point out is that transverse myelitis tends to involve the central substance of the cord a little bit more than it does the periphery, like whereas in MS, you may see more peripheral involvement. A companion case for this case is a 53-year-old with right leg weakness. The patient's had a recent shingles outbreak. Here you see, and in this, the finding is similar, but in fact, a little bit more apparent. You see the cord is a little bit T2 bright here, perhaps a little bit expanded. On the fat saturated imaging, you just confirm that same finding. Maybe a little bit of hazy enhancement centrally in the cord there on your post-contrast imaging, but very similar findings to that previous case. Here you just see the axial images. In this case, it's asymmetric, so you see it mostly in the right side of the cord, kind of centrally and a little bit along the periphery. Here you see a little bit of nodular enhancement in that same region. This patient turned out to have VZV, likely encephalomyelitis in this case. So again, it's a viral illness, and it can also be caused by sort of a viral syndrome or a periviral illness. If this patient got treated and 6 months later, you see those findings have largely resolved. Maybe all you have left is a little bit of linear T2 in the lateral cord there, but for the most part, those imaging findings resolved. In summary, when you have transverse myelitis, many times what you'll see is just isolated findings. You have a normal brain, although you will want to image the brain to see if there's something abnormal in the brain. Many times it can be associated with a viral illness, either a direct viral myelitis or an autoimmune syndrome associated with a viral illness. Now, the imaging features compared to other things that affect the spinal cord, they tend to have a longer segment abnormality. They may or may not have enhancement. And in these two cases, we did see some enhancement. For this next case, we have a 55-year-old man with numbness and tingling of the left upper extremity. Again, you see cervical spine imaging, and you see findings which are pretty similar to that previous case. Starting around C3, extending to C5, you've got some heterogeneous abnormal T2 there. On the pre-contrast, you don't really see anything. And on the post-contrast, you see some enhancement. But unlike the other case, the enhancement here is around the periphery of the cord. You're going to see that confirmed on the axial images here. What you see is some T2 abnormality around the periphery of the cord, kind of these little patchy abnormalities, and then marked nodular enhancement in those regions. So you see pretty solid enhancement there. Now, something I'll point out here is that there is some degenerative change here. So you have this kind of ridged disc osteophyte here, causing some narrowing of the spinal canal, and the spinal cord contour is a little deformed. So that's something to think about. Although in this case, the abnormality is kind of out of proportion to what you usually see with just canal compression. Now, if you take a look at this person's thoracic spine, you're going to see some companion findings, so to speak. On the T2 fat sat, there's some patchy, like kind of irregular abnormalities of the bone marrow. On the T1, similarly, like usually the bone marrow is a little bit more homogeneous. You just see these patchy areas of abnormality, which are a little bit heterogeneous. And on post-contrast imaging with fat saturation, you see similar findings. The marrow is kind of irregularly enhancing there. So something's involving the bones diffusely. Now, what we're dealing with here is a case of neurosarcoidosis. The most classic appearance of neurosarcoidosis is a basal meningitis, so intracranial findings of nodular enhancement, particularly leptomeningeal enhancement, although you can have parenchymal nodules. In the spine, you can see a similar appearance, although what you will often have is T2 hyperintensity and enhancement along the surface of the cord, similar to the leptomeningeal pattern that you see within the brain. As in this case, you can have bone abnormalities, and this person did have some heterogeneity of the marrow. You can see masses both in the brain and spine. These are called sarcoidomas. They're frequently T2 hypointense and have variable enhancement. So you can definitely see that. With sarcoidosis of the spine, what you want to do is you want to take a look at the LP, see what the cell counts and things like that are, exclude other findings. You want to take a look at a chest X-ray and or a chest CT, and some labs such as the ACE level, or sometimes the IL-2 surface antigen also can be abnormal in these patients. So these are things that you can look into. So here you just see the findings that we talked about. So sort of patchy multi-segment cord abnormality with some enhancement, particularly along the periphery of the cord. And here you just see it confirmed again, like on those axial images. But burn this peripheral pattern of enhancement into your mind for sarcoidosis of the spine, because you'll see that enhancement along the surface of the cord. Here you just see those heterogeneities of the marrow that we talked about. And so this is sarcoid granulomas diffusely involving the bones. Here you can see this patient has both kind of or bilateral hilar and subcarinal adenopathy. So you've got some nodes in the chest, which are one of the primary manifestations of sarcoidosis. So that can be a nice clue. It can offer you a nice biopsy target. They can biopsy these through bronchoscopy as well to confirm the diagnosis. In summary, when you're looking at spinal sarcoid, you need to think about a differential. The primary differential is lymphoma, metastatic disease, other inflammatory diseases such as unusual infections. You can have primary spine tumors, and this is a common mimic where you see something that looks like it's an ependymoma, particularly if you have central enhancement. That could be an ependymoma or an astrocytoma. In summary, when you have spine inflammatory disease, the two main things you're going to see are a transverse myelitis, which we saw two cases here with multi-segment lesions in the cord that had some enhancement. They're often associated with a viral prodrome, whereas sarcoid, you often have multifocal disease, but think about that surface or peripheral cord enhancement. Sarcoid is often associated with the systemic findings. So you'll have the lymph nodes, you'll have the brain involvement, you'll have the chest involvement and abnormal ACE levels as well. These are definitely things to think about. Thanks for tuning into this video. Be sure to go back and check out the others from this inflammatory lecture. And in the next few weeks, we'll cover those final two lectures on amyloid-related disease and inflammatory vascular diseases. Thanks for tuning in, and be sure to subscribe and check out the rest of our videos.